everyone, and welcome to our April Journal Club. We're honored to have Dr. Allbritten, PGY2 at the University of Kentucky here tonight. He is a LMU DCOM graduate, and some of his interests include interventional pain and MSK. And then in his free time, he enjoys playing soccer. He likes hiking and rolling sushi. Thank you so much for being here tonight.
Awesome. Thank you guys for having me. Let me share my screen here. All right. Well, thank you all. Definitely honored to be here. Obviously, I've been a member of AOCPMR since first year of medical school. I knew that I was very interested in PM&R from the beginning, so it's always great to come back and chat with you all. Tonight, we're going to be discussing the article Benefits of Resistance Training with Blood Flow Restriction in Patients with Knee Osteoarthritis. Published in 2017 in the Journal of Medicine and Science and Sports and Exercise. Very interesting topic that I actually came across while I was on my outpatient MSK clinic rotation from one of my mentors. And so I thought I'd share it all with you as it has some great PM&R relevance. A little bit of outline for tonight. Obviously, I'll be mindful of y'all's time, but we'll do a little bit of an introduction, background for the paper, go into its methods, discuss those a little bit, really focus on the results though, and then have some discussion about those results, and then what it means to us, you all as future physiatrists, and then we'll go from there. Obviously, I wish I had some disclosures and disclaimers, but I'm a PGY too, so I have none. A little bit about me to start first. That's my wife, Michaela. We've been married for a couple of years, and our dog, Teddy. That's us. That's an accurate representation of us. We're a ball of fun. I grew up in Warsaw, Indiana, just kind of south of the Notre Dame area, about an hour and a half from Chicago. Went to Ohio Northern University. It's kind of up in the Toledo area. Studied biochemistry and played soccer. I've played soccer my entire life. Med school brought me down to the Tennessee area. As y'all said, I'm an LMU DCOMer. Very proud of it. And then transitioned to a residency at the University of Kentucky. And as y'all said, I'm very interested in interventional pain. MSK side of things, perfect world. I would love a blend of the two in my future practice, both doing procedures as well as seeing chronic pain in the clinic. And yes, I love exercising. As I played soccer my whole life, I love getting in the gym. I love hiking. It's wonderful here in Kentucky. I love to travel with my wife, and I am the cook for sure. So I love cooking, like rolling sushi and such. So that's just a little bit about me. But let's dive into it a little bit. So osteoarthritis, as you all know, most common form of arthritis. It's the major cause of a lot of MSK pain, a big cause in functional impairment, as well as reduced independence, especially in the older population. And as you guys know in our learning, osteoarthritis, it's a chronic disease over time. It involves the cartilage, the subchondral bone, surrounding ligaments, a lot of the lower extremity musculature, as well as those soft tissues, such as you guys know, the synovial membrane and the meniscus. And a lot of those inflammatory changes that we really like to focus on and that we can see on X-ray and imaging that help us with the diagnosis of osteoarthritis are cartilage deterioration. We see joint space narrowing, we see osteophytes, as well as some sclerosis and subchondral bone, which points me to the right there of the Kellgren-Lawrence grading scale. And if you guys aren't familiar with this, get familiar with it, because you're going to get either pimped on it or it's going to come up on your board exam. So you should know grades 1, 2, 3, and 4. Grade 1, essentially normal. Grade 2, 3, and 4 goes from mild to moderate to severe. And really that focuses and guides a lot of our treatments, and will actually guide a lot of our talk here tonight during the methods section of this paper. But as you can see there, hip and knee OA, they are the direct cause of a lot of impairment in those that are geriatric population, our elderly population. More than 40% of those who have an impaired gait have subsequent knee and or hip osteoarthritis. So Previous research has done that a lot of the big determinant for physical functioning and risk factors in specifically women with osteoarthritis is in fact the quadriceps muscle weakness and its integral role with the knee. So to talk a little bit more about the quadriceps weakness, we know if we have weak quads, it's been studied, we're going to have worsened proprioception. We have lower extremity weakness. We're going to not know where we are in space. And if we don't know where we are in space and we have that decreased proprioception, we're going to be more tend to fall. And there is an increased frequency in falls. So we know there have been studies out there that show that a reduction in muscle mass in the lower extremities, in those with knee OA, versus controls are correlated with the osteoarthritis disease progression. And big point here for your patients is that they're also going to have increased pain. So that kind of helps us guide, knowing that background and kind of baseline foundation level. We know that our first line therapy for osteoarthritis has to involve quadriceps strengthening and hypertrophy of that muscle. And we most likely get that through resistance training, whether you do that with a home exercise program or with physical therapists. We have to strengthen the quadriceps being first line therapy. So previous kind of that resistance training, that's kind of the abbreviation I'll use for the rest of the paper tonight. Previous findings and current recommendations prior to this paper coming out in 2017, 2018, is that we know that if you have a 1 rep max of knee extension, firing those quadricep muscles, if we have greater than 65% of that 1 rep max, that we know that will certainly improve mass and strength in our quadriceps. And there's a lot of different resistance trainings that are out there, but one type is high intensity resistance training. You guys are probably familiar with HIIT training, or that's high intensity interval training. This is very similar, but essentially translate that to weightlifting. So high intensity resistance training is a way to accomplish this. However, you got to think about that functional part with the osteoarthritic patient. It's going to be limited secondary to pain. So we got to think of some way else to help this pain score, functional status. And that's where blood flow restriction training is becoming more and more of a popular technique. Essentially, at its baseline, it is what it says it is, but it's low intensity resistance training. So that low portion, we're not getting high intensity with partial blood flow restriction to those working muscles. And obviously, as you guessed it, we're going to be talking a lot about the quadriceps tonight, but you can do it for any muscle. And they do this via inflatable air cuffs proximal to the muscles that for working. So you can use it in the upper extremity, certainly if you're working biceps or triceps, you can cuff it in the axilla, but you can start to think of where you would cuff it proximally to work the quadricep muscles. And current research out there prior to this paper, it's limited, but initial research did state that blood flow restriction training was comparable to the high intensity portion promoting muscle size and strength. However, they didn't have a control. And so they weren't able to correlate any of the findings because it wasn't a control in their study. So the purpose of this study was to compare the effects of the blood flow resistance training to traditional resistance training on lower limb muscle strength and mass, functionality, pain, and more importantly, quality of life in specifically women with OA. So let's get into the methods and a little bit of the design. This was taken part in 2011 to 2013 at a university in Brazil. What they initially did is they screened a bunch of participants, about 400 of them, I think 379 as you see on the right there. A lot of them did not meet the inclusion criteria. So there's about 48 that made the cut. And I'll talk a little bit about the exclusion and inclusion criteria here in a second. But 48 made the cut. And of those 48, they're all ranked in tertiles according to their 1 rep max in knee extension. And from there, they were randomized into a high intensity arm, a low intensity arm, and then a low intensity with blood flow resistance. So one that we are most excited to see the results for. And what they did is they took a baseline test, which will be labeled as pre, and a 12-week test, which will be labeled as post for a lot of the figures that I'll be showing here soon. And what they did is they managed a 1 rep max leg press and knee extension. They measured those for all groups. for all three arms. The physical function, which was a timed stands test and a timed up and go. They also measured the quadriceps cross-sectional area and the patient's self-reported quality of life. The patients that they looked for, this was part of their inclusion criteria, had to be females 50 to 65 with diagnosed knee OA. They did this because, well, a couple of things. First off, knee osteoarthritis is more common in females than in males. We know that, that's been studied. And they wanted to just do a single gender to account for the sex variability in muscle strength and muscle mass. Some of the exclusion criteria, I didn't list it because it was a lot here. I have it kind of written down and we can go through it, but essentially at the crux of it, pretty much they could have no treatment for their knee osteoarthritis. They exclusion wise, they couldn't participate in any PT over the past year if they have any cardiovascular disease or musculoskeletal disturbances. Interesting here, they had to be a Kellgren-Lawrence 2 or a 3. So 1s and 4s, if you remember, so that's kind of the two ends of the spectrum. They were thrown out. They had to have a knee pain that was in between 1 and 8 on a scale of 0 to 10. They couldn't have used any NSAIDs, and they certainly could not have gotten any injections, albeit corticosteroid injections or hyaluronic acid injections over the past 6 months prior to this study. So a little bit more in the methods to talk. So we kind of understand the population that we're going after. Now let's talk about the program that they're actually going to go through. So the high intensity arm, what they did 4 sets with 10 reps at 50% of their 1 rep max. They did that for a week. After a week, they transitioned to 80% of that 1 rep max for 1 month. And at that time there, at that increase, they did 4 to 5 sets for the remainder of the time. The low intensity you see there, higher reps, less weight. So they did 4 sets by 15 reps at only 20% for a week, and then they gradually increased that to 30%, and the sets remained the same as the high intensity. As you see there, they were allowed a rest period between sets. Is honestly a really good structured program. Previous to beginning this program, they were all trained on proper form, proper technique they took, and all of this was controlled prior to them starting this program. As to talk about the blood flow restriction pressure, I kind of alluded to it earlier, but here it is in writing, is that they used an air cuff on the inguinal fold, and they inflated that to 70% of the pressure needed to provide complete blood flow restriction. And this was determined via a Doppler on the tibial artery. So what they did is they put a cuff on and they put the Doppler on tibial artery, much more distal, and they pretty much pumped that thing all the way up until they lost signal underneath the Doppler. They noticed the pressure that they were at and then took 70% of that, and that's what they were going to train at. Okay. The functional test that they looked at, as I said, the timed stands test, and the timed stands test is pretty much a patient sitting in an armless chair and how many times they can stand up and sit down in 30 seconds. They also measure the timed up and go. That is patient in an armless chair, stand up, walk 3 meters, turn around, come back, sit down. How long does that take? As you can probably imagine, patients with osteoarthritis in their knee, they're going to have some issues with that. So they wanted to test the functional portion because that's much more functional than just doing like 50% of your 1 rep max on a leg press or knee extension. For the quadriceps cross-sectional area, they use CT imaging. They pretty much took a CT image of the lower extremity, measured the greater troch, measured the lateral epicondyle, the femur, halfway between that, get the cross-sectional area of the quad. And then for the self-reported quality of life assessment portion, they used a couple scales. I actually had to do a little bit of reading on these 2 scales because they were not known to me. One of them is the WOMAC, and that really measured pain, stiffness, and the physical function portion. And the WOMAC is a like 0 to 4 scale, 0 being like no dysfunction at all, 4 being like extreme dysfunction. So you want like a much lesser score with that. Higher score means more dysfunction, more pain, more stiffness. And then to look at the quality of life of these patients, they used a pretty standardized SF-36 health survey. And this took a lot into account, like the psychometrics, the mental health summaries, all of that, to get an accurate representation of their quality of life. So I know I took some time there to go through the methods, but I think when going through a study like this, it's important to understand who the patients are, how they're going to be tested, and kind of what we're looking for and how they assess that. So let's dive into the results a little bit. Let's go first into muscle strength, and I'll orient you here. This is figure 2 in the paper. I'll do a little orientation first. I hope you can see my cursor here. But we'll look for like A and C are both, A is leg press, 1 rep max, and C is knee extension. And then B and D are the corresponding deltas, AKA the change between post and pre. If you see any of these kind of asterisks, that's where we are statistically significant. So those are kind of areas that I'll talk about. And then you can see the white is the high intensity, the charcoal color is the low intensity, and then the black is the blood flow resistance training. And we'll take a look. And this will go across this kind of setup for each of the figures will go across each figure. So let's first look into muscle strength. So we take a look at leg press and knee extension, both at the pre portion. So I'm looking at A and C here in the pre portions, and the baseline, they're pretty similar. So looking at this just points to a good study design and randomization of the patients. Baselines are pretty similar. But then we look within group, we see increases both in statistically significant increases in the high intensity group and in the blood flow restricted therapy. And this is both for leg press and for knee extension. But what's interesting is also to look at the delta analysis. And this kind of confirms our thoughts, is that there was an increase in the 1 rep max for leg press, both for the high intensity and for the blood flow resistance training comparative to the low intensity. But there was no statistical significance between high intensity and blood flow, if that makes sense. So we are both with high intensity and blood flow, both in B and D here. So both leg press and knee extension, we're statistically significant, we're higher, we are improved from low intensity. However, between high intensity and blood flow resistance training, it's not a whole lot of changes. All right, looking at the functional test. So again, very similar setup. We have the time stands test, which is kind of A and B here, and then C and D are timed up and go. As you can see, the baseline scores are comparable for both the time stands and the timed up and go. And looking at kind of within group comparisons, right? So we like to look at those first before we go to the delta. But within group here, we can see that there are improvements in the time stands test, both for the high intensity and for the blood flow resistance training, but there isn't a statistically significant change in low intensity. Interesting enough, not much statistical significance in the timed up and go, both for the baseline within group and with the delta or the change between post and pre. However, there is a statistical significant change in the time stands with the high intensity group, looking at the delta. So we'll go from there. We'll talk a little bit more about that in the discussion, but interesting enough there for the functional test. Looking at the cross-sectional analysis, again, very good study design. There were no differences between the groups at the baseline level at pre. And then looking within the group, so I'm still looking at A here as well, there were only statistical significant changes or increases at the post at the 12-week mark in high intensity and in blood flow resistance training. The delta analysis also kind of trends us in that as well, is that there is a greater increase in the cross-sectional area between high intensity and blood flow resistance training comparative to the low intensity, which we would expect and we saw. However, again, there were comparable effects between the high intensity and the blood flow resistance training. at the delta mark here. No big changes in B between high intensity and blood flow resistance training. Looking at the WOMAC and the SF36, lot of numbers on here. Focus on where the asterisks are, though. We see a lot of statistical changes. First off, for the WOMAC, remember you want lower scores. Lower scores mean less dysfunction. So for pain, stiffness, physical function, and then overall total, we see that blood flow resistance training improves statistically significant at each level at the 12-week mark. However, you cannot say the same for high intensity, and you cannot say the same for low intensity. The SF36 as well, this is more for like mental health and physical health. I want to focus on the mental health aspect there. Really interesting. So everyone's mental health improved. You got a higher score on the SF36, which is good at the 12-week mark. However, look at I know none of them were statistically significant, but look at the change that you see. You see much more of an increase with the low intensity and the blood flow resistance training comparatively. There were some associations that they didn't make, just kind of general overall associations, kind of comparing a bunch of the different results together. They did say that the leg extension 1 rep max had an association with improved stiffness, which I thought was interesting, as well as if we saw changes in the cross-sectional area, that was associated with improvement in the time stands test. So there were associations kind of across results. They didn't really focus on that a whole lot. I wouldn't have either if I was doing this test, but interestingly, it was reported nonetheless. However, I do want to mention this, and this was a big adverse event that they noticed. As you remember, each arm of this study had 16 patients. So there's 48 total that made the cut. So 16 in high intensity, 16 in low intensity, 16 in blood flow resistance training. The one adverse event that they recorded was that 4 of the 16 patients in the high intensity arm were excluded through the follow-up at the 12-week mark because of exercise-induced knee pain. In layman's terms, and how I interpreted that, they couldn't handle the high intensity because they were in so much pain. They had to drop out of the study. So interesting. So let's talk a little bit about it, talk about the discussion a little bit. When we look back at the results, we see that the blood flow resistance training was very effective and very comparative to the high intensity. In the strength categories, in the cross-sectional area, in the functionality, and in the physical function scale, which, as you remember, high intensity was kind of the norm or the first line therapy for knee OA. However, like I talked about, this high intensity resistance training isn't for the faint of heart. There was a statistically significant amount of withdrawals. 4 out of the 16 dropped out because it was too much. So because of that, blood flow resistance training is now truly emerging as kind of an alternative to high intensity resistance training. And the good part about this study is that it evaluated a lot of dynamic muscle strength testing versus a control. We had a control group in this study, and it explained a lot and made a lot more clear findings, a lot more significant findings than previous studies. And we now know that, and even more so, that the quadricep muscle mass is truly an important factor when we evaluate knee OA. We have to know that the lower extremity having lean mass and not having built up quadricep muscles is associated with disease progression, with pain, with severity of OA. And I want to mention this as well, and I kind of have this quoted from the paper, is that the findings of the present study, they support the use of blood flow resistance training interventions in knee OA as it favors preservation of independence. I love how they said that, and thus quality of life in these patients while inducing less strain in the affected joints and consequently less pain. I mean, that's a good day for the doctors. That's a good day for the therapists. That's a good day for the patients. If we're in less pain and we're getting better with our osteoarthritis. So big thing is there wasn't a whole lot of adverse events in the blood flow resistance training. I do want to make mention that we are, and you guys might have brought this up. I want to see in the chat a little bit. Yes, Jennifer. Yeah, all 4 participants that dropped out were all in the high intensity arm. Yes, you are correct. I want to make mention, and you guys, this might be pondering in your head. You're thinking, okay, they're cuffing a major artery in the, inguinal portion, proximal lower extremity. Were there any side effects of, blood pressure, hypertension, et cetera? And the authors kind of filed up on this. They stated that the arterial blood pressure was monitored before, during, and after each training session, and there were no relevant alterations. They showed that the resting blood pressure was not affected at the 12-week mark. So they looked at blood pressures at baseline, they monitored it during the entire training, and then they took it again at the 12-week mark, and there was no significant change in blood pressure, which is huge. Obviously, only limitation to this, as it is with some studies that are kind of coming out and kind of making waves in the PM&R world, is that this was a low sample size. There's 16 in each arm. So it was a low sample size, but significant nonetheless. So what does it mean for all of us? What does it mean for you guys as future physiatrists? First, you'll come to find I am educating every patient, no matter the diagnosis. I'm educating them on their diagnosis and the treatment plan every single visit. So we have to educate our patients on different treatments for knee OA. As you guys know, there's a plethora of treatments that we can do, anything from injections to oral medications, obviously physical therapy and resistance training, but we have to educate them. Where this will come into play and where I'm finding it right now at UK is that I'm putting this in my physical therapy script. Anytime I send a patient to physical therapy or place that order in the EMR, I am including blood flow resistance training if it's a patient with knee osteoarthritis. And what's really cool is that you might be wondering, well, do my local physical therapists, do they know this training? I'll tell you, and I'll be honest with you, a lot of them do know this training. There is specific just online courses that the physical therapist can take and be certified in this part of resistance training. So a lot of them know, and it's becoming more and more and more popular as seen by this results and seen in this paper. So it's cool to include that in your, at least as a consideration, right, in your physical therapy script. And obviously I wanted to throw this in there as well, is that it incorporates both the physiologic portion of knee osteoarthritis, kind of the pathophys behind it, as well as clinical observations, right? Like quality of life and pain scale, and how the patients are interpreting this when they are evaluating knee OA. And this is important that we do in clinic, that the therapists do, that the patients do at home, that they continue to give us feedback. But this paper really lends to incorporating both the pathophys and the clinical portion of that. So those are the references that I have for you all. I will open it up for questions. I'll stop sharing here and just kind of open it up for questions. And yeah, thank you guys.
And start with the one that was submitted. And the question was, prior and post to high intensity resistant training or blood flow resistant training, what kind of stretching routines are generally suggested for patients with OA? And would you suggest icing after these exercises to increase blood flow restriction?
Yeah, really good question. A lot of the, obviously with this paper, they had to be controlled in some way and kind of standardized, and they didn't really talk about any of the stretches that they went through. But as a physiatrist, I would focus on stretching glutes, quads, and psoas, maybe a little IT band as well before doing this, because all of those muscles are incorporated in knee mechanics. So any muscle that's involved in knee mechanics, I would definitely limber up and stretch prior to doing this kind of therapy. As for icing it afterwards, I don't, I kind of deliberated over this after, seeing that question earlier today, but I don't see real true any contraindication to ice. Albeit, you are maintaining a restrictive nature for a longer time. So you kind of have to be wary about that. And that would, come into effect with blood pressure in those. And it lends to the point also of, if a patient, if a patient has knee osteoarthritis, they might have concomitant, hypertension associated with it. So it's a balancing act between, if you want to do this blood flow restrictive therapy, be mindful of other therapies that can also constrict blood vessels. So no true contraindication, just kind of varied on a patient to patient basis, but good question. Jennifer, you got one?
Yes. Hi. Thank you so much for having this talk. I love hearing about BFR and how it's recommended. My question was, when you're referring out to physical therapy for patients to be using BFR, which protocol are you using? I know that there's several protocols that exist, but I was just wondering which one. And if you're referring for a specific protocol to be used, or if you're kind of leaving it up to the physical therapist.
Good question. Myself, I am leaving it up in the hands of the physical therapist, just because they truly know the protocols a little bit better than us as physiatrists. Obviously, if I do dive a little deeper and look at the different protocols, I can certainly throw that in the PT note. I'll tell you this though, my physical therapy prescriptions can get kind of lengthy because I like to include a lot of different things. And I don't want to print off a page for the entire physical therapist. But we have a very good relationship. And I think it also lends to that, right? It lends to your relationship that you have with your physical therapist. I know a lot of them in town, and the ones that we refer to are the ones that patients go to. And I know their education, I know their training, and I trust them to make that decision, what's in the best interest and what fits the patient the best. So at the end of the day, more times than not, I'm leaving it up in the hands of the physical therapist.
Thank you so much. I also had a different question. I was wondering, you may have said it, and I might have missed it. When in this study, when they were deciding which pressure to use, you'd mentioned that they were looking for 70% occlusion. Mm-hmm. Were they using one of the cuffs that is detecting that is specifically used for BFR that's detecting it, or were they using a different kind of cuff to approximate it and then going from there?
Yeah, good question. From what I know, in the paper, and at least what they reported in the paper, they were using a cuff that gave a digital reading of millimeters of mercury. So they were able to see how much pressure was actually within the cuff digitally. And then obviously they just took 70% of that, and that's what they used for the patients.
Great. Thank you so much.
Of course. Good questions. What's up, Kevin? You got one for me?
I did, but Jennifer asked both of my questions actually.
How about that?
Yeah, right. But I guess my third question is kind of an opinion question. So based on going over the study, what's your personal opinion if this were to apply to a male population with OA? Do you think anything would change? For example, from a very big factor that males genetically tend to have more testosterone and less estrogen in their bodies?
Yeah, great question. And it's something that I certainly pondered as well. I completely understand, the design of the study, wanting to eliminate, the sex variability between, a lot of the results that they were looking at. I would really like to see it involved in male population. I was actually kind of joking with one of my co-residents after I kind of talked about this paper with him, and he was sharing videos with me of like these bodybuilders, right, that are like in the gym and they like cuff their arms and they cuff their legs. And, you know, these dudes are like passing out left and right, obviously not using blood flow the right way. But in the right setting, I think it certainly would apply to males as well. I think obviously you have to look at it on an individual basis, right? You have to look at the comorbidities, you have to look at the anatomy, all of that. But I think it would easily translate over to a male population as well.
Cool. Thank you very much. I also have a follow-up question.
Mhm.
And if it's not the right question that you can help answer, that's totally fine. So as a personal trainer who does personal training on the side in medical school, I personally have thought a lot about applying blood flow restriction training, and I unfortunately don't have something like an air cuff when I'm with my clients. So, what are your thoughts, or what's your opinion on using something like a TRX resistance band, one of those smaller rubber band things?
Yeah. I just use caution because like you're not able to, I'm a numbers guy, and you're not able to, you know, measure, you know, it's tough like in young people, right? Like it's not as like I guess as a red flag, so to say. But you got to be careful because I'm a numbers guy. I would want to see like, okay, like I have no idea if I'm getting 100% occlusion
Well,
or
like
I'm
70%,
getting or 70 or 20%, right? Because obviously if you only occlude at 20%, you're not going to get results, right? You have to occlude it to a particular percentage. But I would be wary to just throw a TRX band on there and go after it. I would go through the proper steps of, okay, let's cuff it at this at this pressure and go from there.
Okay. Well, thanks very much.
Awesome. Good questions, Kevin. Thank you.
Yeah.
I just wanted to add on for the purposes of discussion. I've heard that some of the cuffs that are made for BFR will automate their pressure and they'll adjust it based on muscle contraction, which I think is pretty sweet. So definitely something to keep in mind for safety. I think that that's definitely going to help, but those are obviously expensive.
True. Yeah, you're going to pay. Yeah, you're going to pay for it, but it is pretty neat technology. And I think technology will only go up from here in BFR. But pretty neat that that's already, you know, groundbreaking. And this is, you know, kind of, it's relatively new in the field. And it's only going to go up from here, but pretty neat. I saw some of that stuff too. It's pretty cool.
I had another question. I was wondering, I know you had mentioned that they had pretty strict exclusion criteria in this study. And I thought it was interesting that they were excluding people who had gotten an injection within the last 6 months, probably more from like a pain perspective. But I was wondering if you thought that I'm sure it made sense in the context of the study. But I guess, do you think that is something to keep in mind for patients, right? What is your thought on the way that they did their exclusion criteria?
So they had to be restrictive with their exclusion criteria, right? And that's to make a good study, to get a good control, to get a good baseline, right? But that's not the real world, right? The real world is, you know, we have patients that we put on NSAIDs, that we give injections to, but tell them to continue doing physical therapy, right? So I think it's good for the paper and it's good for the study and it gives good results because it gives us a good baseline. But at the end of the day, all of these work together to provide patient with relief, right? Like this is just, it's another tool in the toolbox. It's how I look at it. When I see a patient with knee OA, I have 6 or 7 tools that I can reach for. Well, now I have 7 or 8, right? Because I can add this to it. It shouldn't be looked on as a contraindication. It should just be looked on as, okay, this is how they were control wise in this study, and kind of how restricted that they had to be. But that being said, it's not real world. Good point, by the way. Very good point. Nick, you got something?
Yeah, kind of transitioning into the real world side of things. Just a quick note, 6 months also, by the way, is like a fairly decent amount of time in terms of for steroid injections lasting in knees and in joints and things like that. Not just with the hyaluronic acid, but any like triamcinolone acetonide or anything like that will last a decent amount of time, sometimes longer than 6 months. So I understand why that they kind of wanted that washout period to really make sure that that drug wasn't like confounding the study and they weren't also getting benefits from the drug as opposed to that in addition to the BRT and the or BFR that they were doing. My question is, I'm so sorry. You mentioned that you have prescribed BFR for your patients. What has been your experience with BFR in your patients? How has it affected their treatment?
I have not had, so unfortunate, and this is part of the residency cycle that you guys will get into. I've prescribed it 3 times, all coming within the past couple months. Those patients have yet to have follow-ups in clinic yet. And the bummer is that like every 2 months in residency, you transition to a new rotation, right? Like, so like I will have to, it'll be interesting because I have their like MRNs written down or whatever. I'll have to see their follow-up and how they have done, right? And, you know, make sure the resident, whoever's seeing them, make sure you ask about, you know, blood flow resistance training and see how it worked. So to answer your question in short, I have absolutely no clue, but I'm curious.
I'll stay tuned. Thank you.
Cool. And what I'll do, if there isn't any other questions, I will throw my email in the chat. You guys will love to know that I will answer any questions about blood flow resistance training as much as you want. I will answer any questions you want about residency as well, or this process. Mentorship is huge to me. AOCPMR provided me a lot of mentorship when I was in your guys' shoes, and I love to provide that to you guys as well. So whatever questions you guys have, my phone is on at all times. I will see your email. I will respond to your email. I'll get back to you guys. I'm an open book. So whatever you guys need, I appreciate it.
Thank you so much for coming tonight. It was a great talk.
Awesome. Thanks for having me.